Thank you for joining us today. My name is Yannick Goriev, and I'm the Health Information Specialist with Brain Tumor Foundation of Canada. We are very excited to offer our 9th webinar of the 2013 Healthcare Professionals Webinar Series. Today we have Dr. Joseph Megyesi joining us today. Dr. Joseph Megyesi received his M.D. from the University of Western Ontario Medical School in 1985. After his internship in London, he obtained an M.Sc degree in biochemistry from UWO in 1988. Dr. Megyesi then completed his neurosurgery training at the University of Alberta in Edmonton. During his training, he spent 2 years as a Medical Research Council of Canada Fellow at Harvard University in Boston. At the end of his neurosurgical training, he received a Ph.D. in experimental surgery from the University of Alberta. He joined the London Health Sciences Centre and UWO Department of Clinical Neurological Sciences Division of Neurosurgery as an assistant professor in 1998. Dr. Megyesi's research work and published articles have won a number of prizes in both Canada and the United States. I would also like to add that Dr. Megyesi is our past chair of our board of directors, sits on many committees within our organization, has spoken for us at a variety of events, including information days and healthcare professionals workshops, and the list regarding his involvement with us is quite extensive. We are very fortunate to have him part of our brain tumor family here at Brain Tumor Foundation of Canada. Today, Dr. Megyesi is here with us in the office, and he will be speaking to us about neurosurgery. The title of his presentation is Advance in Neurosurgery, Science and the Scalpel. Welcome, Dr. Megyesi, and I'll hand it over to you.
Okay, well, thank you, Yannick, and thanks for everybody who has come to participate in this webinar. What I'll do over the course of the next 45 minutes is update you on some advances that have been made in neurosurgery. I will start by talking a little bit about what's new in the operating room, and then end off with some words about some research work that's being done in various places around the world. Okay. So the objectives for this first part will be to discuss the workup of a patient who presents with a new lesion in the nervous system, to discuss the approach to the diagnosis of a new patient with a brain tumor, to discuss some of the patient and tumor factors involved in treatment and decision-making for surgery, to discuss the management of acute issues such as increased intracranial pressure and seizures. We'll speak a little bit about shunts, since a number of patients that have a brain tumor might require a shunt. Discuss how we assess the extent of resection after a brain tumor operation, and then just review some of the common complications of surgery. So first, we'll briefly review the types of brain tumors. This is a pie chart that shows the different kinds of brain tumors that are identified in epidemiological studies. The most common type of brain tumor we actually see is a meningioma, which can count for a brain tumor in approximately 27% of the population. The next largest group is the glioblastoma, which is also known as World Health Organization Grade 4. So just to summarize, types of brain tumors, malignant, the main group of primary malignant brain tumors is the glioma group, and the two common subgroups within the glioma group are the astrocytoma and the oligodendroglioma. These two groups can be further divided or further broken down into grades, low grade being the slower growing tumors and high grade being the faster growing tumors. Then the second major category of malignant brain tumor are the metastases. And then the category of benign or non-malignant brain tumors, there are a number of tumors, but as I just mentioned, the most common type is the meningioma. So our first objective is to review clinical presentation of a patient with a brain tumor. So how do these patients come to our attention? So I've tried to divide this into four main categories. The first category are those patients who present with symptoms of increased intracranial pressure. And those would be things like headache, nausea and vomiting, or eventually, if the tumor gets large enough, our decreased level of consciousness. Second major category are the focal neurological deficits. These include weakness or motor impairment, impaired sensation, and speech disturbances. Third major category are patients who present with seizures, and then there are a small group of patients who can present with neuroendocrine dysfunction. So once a patient has been suspected of having a brain tumor, what kind of tests are done? So sometimes we do a blood work, especially in those patients that might have a pituitary tumor or concern for pituitary tumor. So pituitary function tests. For those patients who present with seizure, an EEG might be done. Or for those patients who we suspect might have a metastatic brain tumor, a so-called metastatic workup can be done, which usually includes a CT of the chest, abdomen, and pelvis. Of course, the mainstays for working up a patient that might have a brain tumor are computerized axial tomography, more popularly known as the CAT scan, or magnetic resonance imaging, or MRI. It's not unusual for a patient to first get a CAT scan, and then the lesion is suspected on the CAT scan. The patient will go on to have an MRI. And you can see in the bottom figures a patient with a meningioma on MRI scan, and the three orientations, the axial orientation, the coronal orientation, and the sagittal orientation. And all these pictures help with diagnosis and help with surgical planning. So how do we go about managing a patient with brain tumor? So whenever I speak to a patient in the clinic, I usually go over these three options. For some, all options are possible. For some patients, all options might be a possibility. For other patients, the decisions are more easily made. But just to review all the three options, the first option might be just to follow a patient with a brain tumor. This is not unusual for us to do this for patients who have small meningiomas that are found incidentally, and this would involve repeating a CAT scan or MRI scan at various time intervals, and then have follow-up appointments to see the patient, see how they're doing clinically, and to review the imaging. Second option is a biopsy. Biopsy is often done if the patient has a deep tumor that's not accessible to resection. And there are two ways that we can do a biopsy. One is stereotactically with a frame and a needle that goes to any depth in the brain. Or sometimes we do biopsies open. This allows us to get a larger piece of tissue, which is sometimes helpful if we think the diagnosis is going to be difficult, or if we need more tissue for tumor genetics. The third option is to discuss surgical resection. In some patients, we can anticipate that a surgical resection might be doable. In others, we discuss partial resection. So after surgery, if a patient has surgery or a biopsy, other treatment modalities are reviewed. For certain kinds of tumors, for example, meningiomas that are non-malignant, no other treatment might be necessary if the resection has been complete. However, for patients with malignant tumors, such as the glioma group or metastatic disease, radiation therapy will be discussed with the patient. And then for certain kinds of tumors, chemotherapy is an option. I've put there conventional chemotherapy. By that I mean chemotherapy that's been proven. For example, the use of temozolomide in patients with glioblastoma would be considered a standard treatment. So what are some of the factors involved in making these decisions for surgery? Certainly for the glioma group, the grade is very important. Gliomas can be high grade or low grade, as we mentioned earlier. Within the high grade group are the grade 3 astrocytomas, also known as anaplastic astrocytomas, or the grade 4 astrocytomas, also known as glioblastoma. And then there's also the anaplastic oligodendroglioma group. If a glioma is low grade, it's considered as a grade 2 astrocytoma or a grade 1 astrocytoma, which is really a special subgroup, also known as pilocytic astrocytoma, which complete surgical excision is usually curative. And then also in the low-grade group is the regular oligodendroglioma. And some centers may grade oligodendroglioma as intermediate as well. Now, accepted factors that impact patient outcome. Number of studies over the years have consistently shown that patient age is important. So younger patients generally will do better. Second factor is the patient Karnofsky performance status. So those patients that have a higher performance status, as measured with using the Karnofsky scale, will generally do better. And then, as we've just said, tumor grade. Patients with a lower grade tumor generally will do better than those with a higher grade tumor. In the last several years, there's been increasing evidence that the extent of a tumor resection has an impact on patient outcome. For high-grade glioma patients, it may actually affect patient survival, quality of life, and steroid dependence. There is some controversy as to how much resection is required. Some studies suggest that up to 98% resection may be required for this to have an impact. For low-grade gliomas, it's a bit more controversial. There is some evidence that section of a low-grade glioma may affect the time that it takes for that low-grade glioma to progress to a higher-grade tumor. Others claim that extent of resection might actually affect overall survival. And this is just a chart showing, as I just said, that there is increasing evidence that favors more extensive resection. Number of publications that have come out favoring extensive resection. So a surgeon must weigh several factors when deciding whether to recommend observation, biopsy, or resection of a tumor that looks malignant on the imaging. The patient and tumor factors that I just mentioned. Obviously, the location of the tumor has an impact on the decision. Tumors that are located in eloquent brain, such as the speech area or the motor area, are obviously more difficult to resect. One has to look at the patient's overall condition and other comorbidities. Obviously, the patient wishes are factored in. And then most centers have what's called a tumor board, where the surgeon, the oncologist, the radiation therapists are there, and discussions are taken to try to optimize the treatment of a patient. So what about for metastasis? What kind of factors are considered in that situation? So there are patient factors. So if a patient has metastasis in other locations, this may factor into the decision as to whether to operate on a brain tumor. Obviously, once again, the overall patient condition is important, and then sometimes the estimated patient survival, given their current burden of disease, will be factored in. The type of tumor that the patient has is important. The primary tumor, some are more radio resistant or conversely radiosensitive than other types, and that has to be factored in. If a tumor is relatively radio resistant, surgery might be a better option. Once again, as with the gliomas, location of the tumor is important, and then the number of brain tumors or metastasis that the patient has is usually factored in, and that's why an MRI scan is important, because that's the best way to count the number of brain metastasis that a person might have. So, as I mentioned, relatively radio-resistant tumors, those include the renal cancer and melanoma. Summary statement: in general, a patient with multiple brain metastasis, surgery is not the treatment of choice. However, if one of the metastases is large and symptomatic, surgery may be considered. Also of note is many patients do not die from the brain metastasis if successfully treated. They actually die from the systemic disease. So metastasis in other organs is not a contraindication to resection of a single brain metastasis, because it may improve the quality of life for that patient. Sometimes, if a patient has multiple brain metastasis and no primary is identified, then biopsy of the brain lesion may be needed to make a diagnosis. So what about factors to consider when treating a patient with meningioma? Once again, patient factors. Is the patient symptomatic? And many patients that are referred with a meningioma are in fact not symptomatic. Once again, one has to look at the overall patient condition and the patient's age. Meningiomas are more common as patients get older, and often these patients will have other comorbidities. Similarly, as we've already talked about, tumor factors are important. The location of the tumor and the size of the tumor. Often meningiomas can get very large before they become symptomatic. Meningiomas can be graded. The grade 1 or regular meningioma, the non-malignant subgroup, counts for the majority of patients that have a meningioma. There's a small percentage that are atypical, and even a smaller percentage of meningiomas that might be malignant. So most asymptomatic tumors are observed. Age is generally not a factor if a patient is symptomatic, provided they are in good condition. Location of the tumor is quite important. Skull-based tumors may be very difficult to resect completely, and cavernous sinus meningiomas are also surgically difficult to treat. Size of the tumor may make the surgery more difficult, but it is not in and of itself a contraindication to surgery. And surgical treatment of malignant meningiomas may be as difficult as surgical treatment of high-grade gliomas because of their propensity to recur. So just some pictures as to how we would do a brain tumor operation. What has really been a significant advance in brain tumor surgery is what we call image-guided neurosurgery. This is something that now has been around for 10 to 20 years, but is particularly more important in the last decade or so. Image-guided neurosurgery allows preoperative planning of operations. It allows optimization of the craniotomy, the opening to access the tumor. It allows identification of many structures during surgery. In some cases, it can enhance your ability to resect a tumor, and then it's also a good educational tool. So what is involved with image-guided surgery? So what we do is we place what are called fiducial markers on the head, and those are the little green circles that you see in this picture. Then with those markers on, an MRI scan or a CT scan is performed, usually an MRI scan. It's usually done on the morning of surgery. Then the patient's brought to the operating room and their head is placed in a fixation device like you see here. And what you see in this picture is a image guidance machine. You see a tall camera and you see a computer unit. And what happens is the camera will detect the markers on the patient and will take that information and correlate it with what is seen on the preoperative imaging. So once again, this is the computer screen seen more closely. You can see the tumor is in the cerebellum in this case, and you can see the fiducial markers on the patient's head. And here is one of our neurosurgery residents initializing and correlating the fiducials on the skin against the fiducials on the scan. So why is image guidance helpful? Well, you can see when you've opened the skull and you've identified the dura and the brain, as you can see in this picture, the tumor may not be so obvious. Before image guidance, surgeons would have to sort of use their knowledge and a bit of an educated guess as to the trajectory towards the tumor. But now with image guidance, one can take the probe, place it on the brain, look at the screen to see on the preoperative scan where the tumor is, and then follow the shortest path to the tumor. And there you can see the exposure of the tumor and then the resection that continues afterwards. Another device that we use in the operating room, and this has been around for a number of years now, is what's called a Cavitron ultrasonic aspirator, and it is a device that will use ultrasound to break up the tumor and then a suction attached to the device will take up the particles. In that way, the tumor can be broken up with less pressure. So the future of image guidance. One problem with image guidance is that the scan that you're looking at on the computer screen is a preoperative image, and as the brain shifts, what you're seeing on the surgical field will have changed compared to what is on the image guidance. And what's being worked on is fusing ultrasound with image guidance to constantly update the image that you see on the screen. Another thing that a number of centers are using is intraoperative MRI. This can either be a magnet that slides in and out of the operating room, or even better, a large magnet that the surgeon can work inside of. In my opinion, at least to this point, intraoperative MRI has not proven to be as useful as was originally thought, but I think with more sophistication it may improve, and it's also quite costly, obviously. So there's different ways to do surgery. Is there a best way to do surgery? And what I'm referring to here is more the anesthetic that is used. Surgeries can be done under general anesthetic with the patient asleep, or under what's called the neuroleptic anesthetic with the patient awake. And I think that more and more, in the right situation, neurosurgeons are considering awake surgery, because it allows really more, it allows us to monitor the patient while the surgery is being done. But once again, the situation is usually left for tumor location that's appropriate. So what patients are suitable for awake craniotomy? Patients with a tumor in an eloquent area of the brain, and as I mentioned earlier, that's primarily either the motor area or the speech area. And obviously, you need a cooperative patient for them to be awake and help you as you're doing the surgery. Another thing that awake craniotomy allows is earlier discharge of a patient, since they don't have to go under a general anesthetic. And much of this work has been done in Toronto by Dr. Mark Bernstein. Now, one thing I mentioned at the beginning was to discuss some of the acute issues that can affect patients with a brain tumor. So the first one is increased intracranial pressure, and that usually manifests itself as headache, nausea, vomiting, and eventually decreasing level of consciousness. Probably the best thing that we have to help with increased ICP, at least quickly, is dexamethasone. Patients with a brain tumor often have associated brain edema around the tumor, and Decadron is the single best pharmacological agent for a patient with brain tumor and associated edema. Then if a tumor is large and causing raised ICP, if you can operate on it and remove it, that will obviously help. And then other treatment measures include mannitol, which is diuretic, external ventricular drainage, hyperventilation. These are often used during tumor resection, and then sometimes acutely in extreme cases. Now, what about patients with seizures? Well, obviously these patients will need anticonvulsants. Dilantin is the tried and true medication, a 1 gram loading dose, and then usually 100 milligrams 3 times a day or 4 times a day. If the patient has refractory seizures, Ativan may be necessary. And then for those extreme cases of status epilepticus, patient may require intubation and ICU admission. And then Decadron in removal of the mass lesion will obviously help to minimize the chance of seizure. Now, I thought I mentioned a few words about a shunt, especially in those patients who have a tumor that's causing hydrocephalus. Obviously, if you can take the tumor out and relieve the obstruction, then you avoid a shunt. As it says there, the best shunt is no shunt, but then there are cases where even removing the tumor or partially removing the tumor does not take the blockage away. In some cases of patients with brain tumor, they may have a hemorrhage associated with the tumor, and that can block CSF pathways, and those patients might require a shunt. And then there are cases where a tumor cyst may need to be shunted because it's constantly refilling. So there's different ways to divert CSF. Probably the best way at least in select patients, is what's called a third ventriculostomy. This actually does not require any shunt hardware because it's really a surgically created hole from the third ventricle to the basal cistern. The traditional ventricular peritoneal shunt is probably still the most common way of CSF diversion that you'll see. Or sometimes, as I mentioned, a cystoperitoneal shunt might be necessary. And then there's other types of shunts that are seen more rarely, ventricular pleural shunts or ventricular atrial shunts. And then some people that are watching may be familiar with an Ommaya reservoir, which is sort of like a partial shunt, a way to get medication into a cavity. Now, what about extent of resection? So there are different ways to try to evaluate how much of a tumor has been removed. The long-standing way is the surgeon's assessment during surgery and at the end of the operation, and this has been shown to be notoriously inaccurate. Often surgeons will say things like, I did a gross total resection, or I got most of the tumor out, or I got all of the tumor out. But then when imaging is compared, in fact, not the case. Another way to assess resection is, as I mentioned, intraoperative MRI scan or even intraoperative CT scanning. But once again, this has got mixed reviews. It can be somewhat awkward and is helpful in some cases, but not in all cases. Then I think really the best way to evaluate extent of resection is with post-op imaging. So a post-op CT scan and or MRI scan, and MRI is really the preferred modality. Ideally, the MRI scan should be done within 48 hours of the resection. You should get a T1 with gadolinium as well as a T2 scan. Another reason to do an MRI scan postoperatively is many clinical trials now require patients to have imaging that has been done within 48 hours. And then the criteria that has been used traditionally is called the McDonald criteria, but this is primarily CT-based, and this is being updated by a group called the RANO group, which is radiographic assessment in neuro-oncology, and over the years some new criteria are being developed. So just a few words on complications of surgery. Bleeding, it's not uncommon to see some blood in a resection cavity, but usually this is not symptomatic and usually resolves on its own. Fortunately, infection is not that common. It's usually Staph aureus. It's usually extradural. In many cases, if it's just on the skin, it can be treated with antibiotics, but if it gets deeper and starts to involve the bone, then the bone usually has to be removed. Some patients will have postoperative collections of fluid in the subgaleal space. Usually this is serous fluid and usually resolves with some time and some pressure applied. Occasionally it may need drainage through a needle if it persists. And another thing that we see are postoperative CSF leaks. Once again, these aren't that common. Many resolve spontaneously. Some require lumbar drainage to divert the CSF until the small hole will heal or seal up. And then occasionally, for those who are not successfully treated with a lumbar drain, they may require reoperation. And of course, a person that has a postoperative neurological deficit, that would be a complication. Fortunately, that's not that common. And then some people consider suboptimal resection of tumor a complication. Usually that's more a reflection of the surgeon's assessment during operation and what they deem as being safe to resect. Functional MRI, this is a newer modality that we're using more in the operating room, before surgery. This is a way to map out the motor area or the speech before the patient actually undergoes surgery. It's done in an MRI scanner, usually a few weeks before surgery. Patients asked to do different motor or speech tasks, and this allows mapping of what appears to be the area that involves speech. And then when you actually do the surgery, you use that information to plan the trajectory you're going to use towards the tumor. It's not a substitute for having a patient awake, but it can supplement preoperative information from just an anatomical scan. I think I'm just going to skip through some of these pictures. This is more some of the research applications of functional MRI. So I'll just zip through these. This is some of the theory behind functional MRI and how the tests are actually done. I suppose you can look at this afterwards and go through it slowly. How accurate is functional MRI? It's really pretty good. We've done some confirmatory testing where we've done functional MRI and then done some intraoperative mapping, and the correlation seems to be quite good. And the functional MRI can also show us how the brain can adapt to a tumor and have some of the eloquent brain relocate. So just in summary, functional MRI allows surgical planning but is not a substitute for having an operation done awake, and it helps us understand the brain better. So now I'm going to roll through some research things. I'll be fairly quick, but also somewhat superficial. We'll talk a little bit about tumor angiogenesis, talk a little bit about tumor invasion, talk a little bit about brain tumor stem cells, a little bit about signal transduction and tumor pathways, and then just tie in the role of the Brain Tumor Foundation in some of this research work. So the first topic is tumor angiogenesis. I'm personally quite familiar with this. This was some of the research I did when I was in Boston. And one of the founding fathers of the concept of angiogenesis is this individual. His name is Dr. Folkman, and I worked in his lab for a short while, a couple years. The theory is that tumor cells can divide and multiply on their own without a blood supply for a while. But when they reach a certain size, in order to keep growing, they need to get nutrients through the bloodstream, and they release factors into the bloodstream that then draw in blood vessels to them. And then more factors, and then more blood vessels, and eventually the tumor takes off and grows quickly. And glioma, brain tumor, is one of the more highly vascularized tumors in the body. So a number of factors have been identified that the tumor can release. 3 of them are listed here: basic fibroblast growth factor, vascular endothelial growth factor, and some compounds called angiopoietins. Time has shown that the most potent factor is the VEGF, the vascular endothelial growth factor. Over the years, a number of compounds have been identified and developed to try and combat these growth factors, to slow down or prevent growth of tumors. A number of them are listed here. And some of them have actually worked quite well in animal models, but were not really translated into humans. In fact, at one point it was thought that angiogenic treatment might actually cure cancer, but Dr. Folkman was the first one to say that he's flattered, but it's mice, only mice. If you have cancer and you're a mouse, we can take good care of you. So currently, probably the most, or the sort of well-known current compound that is an anti-angiogenic agent is a drug called bevacizumab. It's an anti-VEGF compound. Trade name is Avastin. It has been approved by the U.S. FDA for use in recurrent glioblastoma. However, the evidence used for this approval was really a rather mediocre study, some would say, but nevertheless it was approved. Recently, 2 randomized controlled trials for newly diagnosed glioblastoma in fact showed that bevacizumab did not improve overall survival. So really, the jury is still out on anti-angiogenic compounds. I think they're probably going to have some use, but by themselves will not actually cure tumors. Second area we'll go over is what's called brain tumor invasion, and I think in some ways brain tumors are unique amongst cancer in the body in that not only do their growth depend on cell division and angiogenesis, but also on the tumor's ability to invade and grow into the surrounding tissues. And this, of course, makes brain tumors more difficult to treat. So some of the issues around invasion: can brain tumor invasion be blocked? Can chemotherapy be tailored to meet individual patient requirements by doing work in the lab? And is there a pre-screening assay that can provide clinical guidance for primary and secondary chemotherapeutic? And I'll just show you very quickly some of the work that we're doing locally around brain tumor invasion. What we do at the time of surgery is we collect tissue for the pathologist, we collect tissue for tumor bank, and we also collect some tissue to use in an invasion assay. Basically what you see is a tumor explant being put into a collagen matrix that mimics the brain, and then we can monitor the growth of this tumor to see if it gets bigger and invades into the matrix. And then what we can do is test different chemotherapy agents on the tumor to see if they block the growth and invasion. This is a little video which I don't think will work on this screen, but it basically shows tumor cells invading into the surrounding matrix. And then what we do is measure the distance of the invasion. Then we would treat with a chemotherapeutic agent and see if that invasion distance is decreased or blocked totally. So what we've shown is that tumors display a unique invasion and response profile, that individual response to chemotherapy is highly variable, and this certainly is seen clinically as well. And I think it's really too early to say whether a pre-screening or responsiveness will necessarily reflect clinical treatment. Now, what about stem cells? A lot of people that might be watching this have heard about stem cells. What are glioma stem cells? Truth is we're not exactly sure, but they may be a minority population of cells in a larger tumor that have a tendency to create the other cells in the tumor. And it may be that it's these stem cells that are in fact the ones that are difficult to treat. And some of this work has been done also in Canada, particularly in Toronto. What you see in this diagram is sort of a cartoon figure showing the responsiveness of non-stem cells versus the resistance of the stem cells. I've tried to simplify it with these little characters here. That soldier at the top is a regular brain tumor cell, the funny-looking soldier is the stem cell, and then the treatment, whether it's surgery, chemotherapy, or radiation therapy, is the tank that tries to destroy these cells. Basically what you would have at initial tumor growth is the stem cell, and then the regular cells would sort of arise from the stem cell and keep dividing, and then they invade, so like a brain tumor, cell division, cell invasion, and then the tumor becomes large and symptomatic, and we become aware of it, and then the oncologists, surgeons, radiation folk, we try to kill the tumor, and often we're successful at removing much of the tumor by the different modalities that we use. But unfortunately, the theory goes that the stem cell evades treatment and then goes on to cause tumor recurrence. So once again, tumor cells all recur, invade, and then we have a tumor board where we discuss what the next phase in the treatment is, and we try the same thing or try something different. We eliminate a large proportion of the cells again, but unfortunately the stem cell survives all the treatment and the whole cycle recurs. So obviously, if you want to try treating tumors, you have to treat the stem cell, and there are some paradigms that have been suggested in vivo and in vitro to try to get at stem cells. But simply, we just want to eliminate them. And I think there's going to be some more information coming out on stem cell and stem cell treatment in the future. Now, what I want to touch on next was something you may have heard of called the Human Genome Project. This was actually completed a few years ago, and this involved mapping the human genetic sequence and the so-called Cancer Genome Atlas. And the goal is to systematically catalog the main genetic mutations in different types of cancerous tumors. Very expensive project, upwards of $1.5 billion. This slide's a bit dated here, but the glioblastoma tumor has already been sequenced. These are the papers that came out a few years ago in the prestigious journal of Science and Nature with the human GBM analysis. And this diagram is also trying to show you that there's different pathways that tumors can follow. I mentioned earlier that tumors can be low-grade or high-grade. There's good evidence now that some high-grade tumors start out as low-grade tumors and go through a sequence of genetic alterations in order to become high-grade tumors. And we call those glioblastomas, secondary glioblastomas, versus glioblastomas that just arise from brain cells quickly rather than passing through a low-grade stage, and we call those primary glioblastomas. And the treatment of these kinds of glioblastomas may differ, and they may occur in different populations of people. This just shows some of the genetic alterations that are thought to be most important in brain tumor. Quite simply, it's becoming very complicated, the different pathways tumors can take to progression. Now, this, once again, is my effort to simplify this. You have a tumor cell. What happens is that the tumor cell gets a signal, and that allows the tumor cell, through a process called signal transduction, to either proliferate, undergo angiogenesis, or undergo invasion. And really, what we want to get at is the signal. We want to try and block that signal. And then, if we can block the signal, then theoretically we can block angiogenesis, or block proliferation, or block invasion. But as that complicated diagram just showed, there's many different pathways that tumors may take to get to the endpoint. And what happens is it becomes like a bit of a whack-a-mole sort of game, where you block one pathway, but as soon as you block one pathway, another pathway takes over, and the tumor grows, and the same result happens. So the tumor will invade, or proliferate, or draw blood vessels to cause angiogenesis. So really, we need a better understanding of the genetic makeup of brain tumors, and this is happening. We need better understanding of the signaling pathways in brain tumors, and this is happening. And we need to translate this understanding into better treatments. And what is theorized is that possibly each individual will have a separate or a different treatment regimen compared to another individual, even though the tumor might have the same name. The process is slow, obviously. So finally, I just wanted to draw in some of the role of the Brain Tumor Foundation in brain tumor research. Brain Tumor Foundation is a big supporter of research in Canada and in other locations, in partnerships with other foundations. One of the signature things that the Brain Tumor Foundation has supported pretty much since the beginning is brain tumor tissue banking. Basically, what tissue banking is the collection of tumor tissue at the time of surgery, and then the tissue is preserved so it can be used by researchers to find cause and cure for brain tumors. And the Brain Tumor Tissue Bank, as I said, is funded by Brain Tumor Foundation of Canada, and tissue from the bank has been sent around the world to help researchers. And it has been recognized in a number of forums as a leader in tissue banking. What else? Brain Tumor Research Foundation gives grants. These are 2-year grants to Canadian scientists, and they're up to $25,000 per year. The number of grants varies in years, and the next granting cycle is coming up in the next few months. Brain Tumor Foundation is also part of the Brain Tumor Funders Collaborative. This is a North American initiative to fund large research projects, and these have been up to a couple $1 million when we partner with colleagues in other countries. And then we also have a research fellowship program, which is designed to fund young scientists or medical residents to do further training in the field of brain tumor research. And, this program has grown in the last couple of years from 1 fellowship to possibly 4 fellowships in the next few years. Some of the research we've supported has led to possible treatments, and this is acknowledging some people that have given us donations for the fellowships and the grants. And As somebody watching this, you can help. Tell your patients about Brain Tumor Foundation of Canada. We have handbooks and other literature that you can distribute to patients and their families. We have support groups that you can make patients aware of. And then obviously we have fundraisers such as the Spring Sprint or other events to support the organization. This is the next seminar, correct? Yes, there it is. This week. And questions?
Thank you so much, Dr. Megyesi. Once again, you've presented this information in a way that that we can understand, and we appreciate you taking time out of your busy schedule to join us today. And as you heard, Dr. Megyesi is a big advocate for Brain Tumor Foundation of Canada. And just to echo what Dr. Megyesi said, we really encourage you to refer patients and families to us for support and information. And also what I would like to encourage everybody to do is check back on our website in early January at www.braintumor.ca for our 2014 webinar series that we will be launching. So thank you again for joining us, and have a great day.